Hey guys, it's Alicia here, a medical laboratory sciences student at CUT. Have you ever experienced just waking up every day feeling like you're trying to piece together your life like a jigsaw puzzle, only to find some pieces are from someone else's nightmare? It's like living in a real life murder mystery where you're the detective, the suspect, and the victim all at once. This is the reality for most people diagnosed with dissociative identity disorder. So, what is dissociative identity disorder, also known as DID? This is a rare psychiatric condition typically stemming from childhood trauma or abuse. It affects approximately 1.5% of the population and is often mistaken for schizophrenia or psychosis. DID is characterized by identity confusion or alteration, sometimes described as exhibiting multiple parts of the personality, memory problems, including amnesia for traumatic past events or distinct personality states. Many individuals with DID display symptoms similar to those of borderline personality disorder and post-traumatic stress disorder. However, it is important to note that DID is a type of dissociative disorder and not a personality disorder. Dissociative disorders are mental health conditions characterized by a disconnection between thoughts, memories, feelings, behavior, and identity. They typically arise as a response to traumatic events and can lead to difficulties in everyday functioning. Symptoms range from memory loss to the presence of multiple identities, and stress can exacerbate these symptoms. This is the major reason as to why the disorder was renamed from multiple personality disorder to dissociative identity disorder. This patient case report involves a 20-year-old woman who presented at the emergency room following a suicide attempt. Upon admission, she exhibited disorientation, confusion regarding her surroundings, and experienced amnesia. Given her medical history, the patient was referred to the Pottergate Center for Assessment of Dissociative Disorders. The patient did not have any significant medical history before the age of 17. However, she started experiencing depression and anxiety at the age of 17, and at the age of 18, she began therapy. Initially, her psychiatrist at the time diagnosed her with bipolar disorder. However, she also suspected psychosis, but ruled that out. Later on, when she suggested dissociative identity disorder to the patient stopped therapy due to denial and experienced worsening health, including seizures and self-harm. The patient was admitted into the hospital multiple times for non-epileptic seizures and her continuous attempts for self-harm and suicide. The symptoms the patient exhibited were anxiety, depression, dissociation, memory gaps, and non-epileptic seizures. She also experienced alcohol abuse, blackouts, and suicidal or self-harm attempts. It was also noted that the patient was catatonic without drinking alcohol or any signs of autobrewery syndrome. The patient was transferred to Pottergate Center for diagnostic assessment. These also included therapy and questioning. Multiple dissociative assessments were also conducted, which included Dissociative Experience Scale 2, DES-2, DES Taxon, ADES, SDQ-20, and SCIDD. The DES-2 indicated a high probability of PTSD and dissociative disorders. However, SCIDD assessment confirmed diagnosis of dissociative identity disorder. Sadly, there is no cure for DID, but it can be managed. The patient was recommended psychotherapy twice a week to learn about the disorder and communicate with alters. Individual therapy was also recommended for self-acceptance and structured treatment plan for at least 3 years. It was also important for the patient to develop a structured system.
When the patient revisited, improvement in symptoms were evident as she had formed a harmonic system. However, the patient is no longer the host due to a few alters fusing together, and the host, the patient herself, fused with other alters to form a new host. Alters are different identities, could be male or female. Fusions are when two or more alters fuse together, combine together to become one. And fronting is basically the alter you are talking to, or basically somebody that's doing the work or talking.
So let's talk about the neuroanatomy and the pathophysiology of DID. So, individuals with DID exhibit distinct neuroanatomical and pathophysiological characteristics compared to typical individuals. Neuroimaging studies reveal smaller volumes in cortical and subcortical regions, including the hippocampus, amygdala, and parietal structures, alongside enlarged white matter tracts, facilitating communication between brain regions. Moreover, females with DID demonstrate reduced brain thickness and surface area, particularly in regions associated with emotion regulation and perception. The pathophysiology of DID implicates early childhood trauma, leading to neurobiological alterations such as changes in brain structure and function, dysregulated stress response systems, including the hypothalamic pituitary adrenal axis, and disrupted white matter tracts. These neurobiological changes underpin the fragmented sense of self and distinct physiological responses observed in individuals with DID. Individuals with DID have a plethora of symptoms. These include anxiety, depression, self-puzzlement, disordered eating, self-destructive behavior, etc. Additionally, DID could often lead to misdiagnosis with PTSD, psychosis, schizophrenia, bipolar disorder, and ADHD. The diagnosis of DID involves specific criteria outlined in the DSM-IVTR. This includes the presence of two or more identities, disruptions in the sense of self, memory gaps for everyday and traumatic events, and significant distress or impairment in functioning. Doctors employ detailed psychiatric interviews and specialized questionnaires, along with physical examinations and lab testing to diagnose DID and rule out other mental health issues. There is no cure for DID. However, treatment for DID lacks standardized guidelines, but typically involves a long-term commitment. Psychotherapy, including cognitive behavioral therapy, dialectical behavioral therapy, and hypnotherapy, which aims to integrate distinct personality features, manage stresses, and develop coping strategies. Adjunctive therapies like arts or movement therapy help reconnect with dissociated parts of the mind, while eye movement desensitization and reprocessing therapy facilitate trauma healing. In conclusion, treating DID is challenging, but long-term therapy can significantly improve the lives of those affected. Psychotherapy like CBT and DBT helps integrate different personalities and develop coping skills. However, accurate diagnosis is crucial and requires thorough assessments. Collaboration between patients, families, and healthcare providers is essential for effective management. The patient's journey at the Pottergate Center highlights the importance of tailored interventions and support systems in the DID treatments.
Here are a few references that I cited in this video. However, you can follow the last link to get a full list of references and citations. Bye bye.